Hi, good afternoon. I'm Candace Willett, Pediatric Nurse Practitioner at Jemsek Specialty Clinic. Today, myself and Dr. Jemsek are going to be answering some questions which happen to have a focus on pediatric health, but certainly a lot of questions will be dedicated towards Lyme disease in the adult population. We're going to have a conversation today, go through some of your questions that you've posted and some that we've collected, and give you some time to join in to the live feed while we get organized. I'm just pulling up the post right now. Okay, there we go. Excellent.
I just want to add our welcome to you out there in cyberspace who have been so very kind to us, and quite honestly, it's a privilege for us to do this and educate. We don't know everything, but we know a lot about what we don't know, and I think that's more important. But we're able to answer some things that are so confusing, and with our experience, we can at least tell you what we see and what we've done in the past, recognizing that we are at the very beginning of understanding this very complex illness, which is afflicting millions of people around the world.
Now to start, we've compiled a list of some of your questions that you've submitted over the weekend. And to begin, we've got some questions directed to Dr. J, and both him and myself will answer a few of those questions. To start, Dr. J, first question, do you know of any parents with kids who have been afflicted with Lyme disease?
Yeah, it's just like a lot. We have entire families, I'd say 150 at least, where the majority of the folks, including the adults, are infected, which is a strong, strong intuitive evidence for the fact that there's a lot of vertical spread of this disease and all kinds of expressions and growth in the children. Fortunately, most don't have severe fetal malformations, but then as they age, they tend to have issues with learning, with disruptive behavior, with attention, with the tics, sleepwalking, bedwetting. And Candace, can you talk about some of the female menstrual issues that you've seen?
Sure, absolutely. Sometimes we can see different abnormalities, and this could be from either having very early onset menses, which doesn't correlate with mother or grandmother and their onset of menses. Could also be the other end of the spectrum where we see very late onset, so concerns about where hormone levels are as it relates to inflammation in the body and where the immune system is at too. So many different things we see, including different delays in developmental milestones. Infant history is very important, early childhood history, things that are unusual and abnormal that present in primary care can be big red flags for us.
And of course, a lot of this stems from the hypothalamic pituitary dysfunction, which is so common. This area is very vascular, and if you have a central nervous system infection, can guarantee in many cases, if not most cases, that you're going to have disruption of normal function there.
This actually brings us to a good secondary question. Do you think most kids, Dr. J, have Lyme disease passed on congenitally, or could it perhaps be from exposure in the environment?
So while it could be both, I think congenital makes a lot more sense because we know about the spirochete. Now, just acquiring the spirochete by itself may not be create symptoms and dysfunction with child development, but and we know very little about transmission of some of the co-infections. We believe very strongly that co-infections play a major role in the expression of Lyme borreliosis complex. And however, I think the Lyme spirochete by itself can cause some problems in development as well. And let me just say one more thing. We haven't studied this. I think the government, CDC, is frightened to do this so they don't, put the nation in panic. We've got enough stress right now with COVID, but this has been going on for a very long time. And without adequate testing measures and interest, money, we don't know. And I don't think the government wants to know, quite honestly.
It kind of leads us to our next question. When it comes to treatment for children, do kids get better faster as compared to adults?
As long as they treat the parents first. So, we treat mama first usually because, there's so much stress. It's not always that way, but usually that way, where mother's infected and symptomatic. We try to treat mom or at least get her stabilized because she's, this poor individual's dealing with her own health problems, and then she has sick children that she loves and great concern. We'll do some palliative things for the kids usually, but try to get mom stabilized. Sometimes mom says, "Go ahead, I'm fine. I'll struggle through and power through," right?
Absolutely.
And so we get that as well. We have a conversation with the family. This is how are you doing? Do you feel like you can get treat the kids first, or are you okay, or should we get you stabilized first?
Absolutely. It's always in pediatrics a conversation and consideration for where parents' health is as it relates to children, and who would also function as the support person for that parent going through treatment. As we know, it's a team effort really to get children well as parents in our practice. And with the support of Dr. Jemsek and the other providers and our support staff, really working together, that's what gets people well, keeps them well too. So another question moving forward, if kids aren't symptomatic, should we treat? Should we use antibiotics? What's your thoughts, Dr. J?
My thought is that not only for children but for adults who have positive tests, for example, I don't see positive tests as an indication of disease. I see it as an indication of exposure. Of course, there's lots of false negatives, maybe half, 50%. We're not smart enough to know what to do about that, quite honestly. If we have an individual test positive in the middle of a family that is symptomatic and are worried about their health, our first approach and main emphasis is lead that low inflammatory lifestyle. Do all the good things that you can. Let's deal with anxiety in different ways, whether it's exercise or reading or meditation or what have you. It's all about trying to keep the immune system ahead of the curve.
Absolutely. And perhaps we can even think about, should we be monitoring children for any abnormal behavior or anything out of the ordinary, what their exposures might be, considering making sure that they're sleeping well, that they're getting adequate rest, eating healthy, taking care of their bodies, just as we all should be doing to keep us healthy.
Right. I think a lot of times Candace will, and the rest of us will say, okay, let's try some empiric antibiotics very gently and see if we get a reaction, because we get a reactions compatible with neurologic irritation using antimicrobials. That's a pretty good way to, pretty good indicator that, we may have to do more extensive therapy in the future.
Absolutely. This kind of leads us into the next question that we could think about. What suggestions do Jemsek Specialty Clinic have for kind of minimizing the chance of relapse from occurring once treated and in remission?
That is a good question. So whoever wrote that, thank you. We hate relapses. We hate relapses. We don't like relapses at all. And feel badly about it, knowing that the patient feels much worse than we do. So we have a list on our website of 25 conditions that may either obstruct or confound care or treatment. or prohibit treatment. And some of those that obstruct or confound, if we don't recognize those, can still be around at the end of our treatment, even though the patient's done well. Number one cause of relapse is recrudescent babesiosis. Number one. Number two is babesiosis. And that's a pain, because when they come back in with a swollen liver and spleen and they're starting to rev up with some of the previous symptoms and are stuck, then on exam we find that we say, you know, it's come back and we have to treat you, because babesia will block the immune response and upregulate the residual spirochetes, because we never rid ourselves of the spirochetes entirely. May reactivate other conditions like ileitis or others. So it's a pain, but we go back and do a 5 or 6 month program, and that includes the familiar artemisinin group and annula cryptolepis, atovaquone, antimicrobials that support, and it's difficult, but you know, we get people better. Now here's what we're going to do. Because we really work hard, as our patients know, to reduce babesia and try to eradicate it, but we don't have the immune system helping us at that time, if you think about it. So it's imperative that early on we start biofilm and treat babesia, but recognizing that we're handicapped, and people get better as they go through our 1-year program, dosing, you know, 8 to 10 days a month. After folks get into maintenance, particularly those who were severely impacted and severe life alterations, maybe even needing IV therapy, what we're going to do, or have start doing in the future, and most patients accept this, is once you're in maintenance for 3 or 4 months, we make the assumption that your immune system is much improved, it's reconstituting. And we've told our patients, we are going to treat you again for babesia, because now we have your immune system in tow. And so we're probably going to do 2 or 3 months of intense babesia treatment, which won't be fun, but then the patient will get through that and go back to maintenance. And in doing that, we're confident we can reduce our relapse rates by 80%, I would say.
That might lead us into, maybe we could educate some of our followers in regards to what we're promoting here in the clinic for some immune support to get through for COVID, and to perhaps even minimize some symptoms. What are some supplements that we seem to like?
So I did a webinar with Academy of Nutritional Medicine in London about a month ago, and actually I'm going to speak with them tomorrow, because they had more questions, so I said, okay, I'll do another hour. And in that, there are slides there, and in our research, we found that nattokinase, which is a fibrinolytic agent generated by enzymatic reactivity of the bacteria Bacillus subtilis on soy, creating this molecule, which is a fibrinolytic, breaks down fibrin, and as most people know, the consequence of COVID is coagulation once it gets past the immune system, and then the immune system playing catch up, and you get this inflammatory storm. So I think the immune system can't contain it, because there's poor communication, and in the elderly, there are 2 sets of immune response: innate, which is on the front end, and whose job is to deliver antigen to the adaptive system, who are the sharpshooters. When that doesn't happen, either because of genetic vulnerability or because of aging, then patients can get into the severe complications of this illness. Nattokinase inhibits a compound called prothromboplastin activating inhibitor -1, which is upregulated, which creates a lot of clotting. So nattokinase, which is gentler than aspirin, will mitigate that. It's very effective. There are 2 articles in the last 5 years in academic journals which support that. And we don't feel like there's a lot of biofilm degradation that would complicate things. And then we pair it with what the CDC has been recommending, which are various levels of vitamin C, vitamin D, zinc, and quercetin, Quercetin, which is a bioflavonoid, which inhibits or does a good job of knocking back IL-6, which is the main pro-inflammatory cytokine in this process. And so I've mentioned this on live stream before, and I've done it in the webinar, and we do it with all our patients. I haven't put it on the website, but I feel very confident that in terms of moderating illness and absolutely mitigating the severe consequences of the illness, a program like this is very effective.
Absolutely. We even support it for some of our pediatric patients as well, too. They certainly could benefit from some immune support, too. Important to note, too, our PD patients are just as vulnerable as the adult population. Not to forget that when it comes to COVID-19. Now to transition, Dr. J, there's some questions in regards to PANS versus Pandas and versus Lyme and its connection. And I know we certainly have a stance on that. Would you mind sharing some of that, and I'll help?
Yeah, I'll need your help.
Absolutely, absolutely. We can do this together.
We can do this together. So I met Dr. Cunningham in London a couple of years ago. Lovely lady, gave a very nice lecture. People talk about active infection in Lyme borreliosis. There is some autoimmune activity going on, and certainly Hashimoto's, is extremely common. That's an autoimmune phenomenon. But guess what? When we treat with the antimicrobials, not only with Hashimoto's, but with seronegative rheumatoid and some other connective tissue disorders, antibodies go down. They may not go down to normal, but they're reduced. So I think that the driver is still infection. Think about it this way. If you have these very invasive organisms, Bartonella, things that are intracellular, Borrelia, maybe mycoplasma even, they're sort of tilling the surfaces of these cellular entities and turning them upside down and ripping things up and exposing new antigen, intracellular or otherwise, to a dysfunctional immune system. So now we start making antibodies against ourselves. And I think that happens with PANS and Pandas. I do not think that Streptococcus plays a primary role. I think it's a phenomenon of molecular mimicry. So, you get antibodies that look like they're against Streptococcus. Trust me, if you have a primary streptococcal infection in the lower brain, you're going to be dead. It is not a gentle organism. But yet, we get these antibodies, and, Dr. Cunningham has developed different panels and so forth. I'm very happy to see that she's still operative, and that's what she told me. So we think it's in the spectrum of Lyme borreliosis complex with a twist. We think that certain parts of the brain are involved, including the hippocampus and the cingulate gyrus in particular, maybe the brainstem, to create some of the symptoms which Candy can elaborate on.
Absolutely. So when we think about Lyme disease and tick-borne illness, it can cause this acute inflammatory presentation leading to neuropsychiatric symptoms in particular. So that could be acute onset anxiety, OCD, mood lability, sometimes tied to ADD, ADHD. Can start to see issues in children with short-term memory, executive function disorders, impulsivity. These neuropsychiatric disorders are most known with PANS and Pandas, but we absolutely see that with Lyme disease and with our diagnosis of Lyme borreliosis complex. And certainly motor and vocal tics are also a part of that, and very much seen both with PANS and Pandas, but really with LBC as well. Our children do very well with treatment. Antibiotic, antimicrobial treatment is warranted. And it actually leads us to our next question. If, let's say, one of our young adults was diagnosed with PANS, Pandas, they're treated for LBC infection, is there the possibility of it then reemerging and affecting them as an adult in the future.
So I think the question is, what part of the brain regenerates the best if you've eradicated infection? So a mantra here is that, that neural channel, that peripheral nerve, that brainstem area, and pockets in the brain can't heal unless the infections are gone. And not all parts of the brain heal equally well. The ones that I'm aware of that do pretty well include the lateral ventricles, hippocampus, and amygdala, which is not bad. That's a good thing. But I think that, the cortex, for example, our thinking brain, can re-network. It may have lost a lot of cells and regenerated some, which it will do automatically, but not back to baseline, I don't think. There's a lot of study that needs to be done in that area. So in terms of somebody having PANS, PANDA, or LBC for that matter, those damaged areas may persist for years, and they'll behave if the patient sticks with a low inflammatory lifestyle and they don't have exposure to a major stressor, which, folks can't control a lot of that. Sometimes they get life circumstances which set them off a year or two afterwards. We just talked about Babesia. We're going to try to take that one off the table. But still, think about it. It's like scorched earth in some parts of the brain. And if you have a flood of toxins 2 years later, 3 years later, you may activate a little bit. And that doesn't mean that active infection has come back full force. And usually it's temporary, and you should control it with medications.
We answered this question briefly, but I'm going to go back to it because we had a question about not only antibiotics, but is IVIG something that we support with treatment, especially correlated with Pandas? And we have a perspective on that. Typically, and Dr. J, you could finish here, we don't commonly prescribe IVIG. Realistically, IVIG is only warranted with a diagnosis of immunodeficiency, and certainly some patients may need that, but that is coordinated with immunology, and if they do require treatment for LBC, then it would also be coordinated with antimicrobial treatment too.
Yeah, if the patient comes to us and has been seeing an immunologist or a neurologist and getting IVIG, we're kind of okay with that. We can work around it. I look at IVIG, I have experience with IVIG as an infectious disease person for the common variable of immunodeficiency, which is real, and where people have immunodeficiency in IgG predominantly, but it could be IgA or IgM as well, and they end up with recurrent sinus and pneumonia, primarily with encapsulated bacteria such as pneumococcus and Haemophilus influenza. So I've done it for that, to keep people out of the hospital. What we're seeing in our world, which is sadly not reported, is a high prevalence of acquired immunodeficiency on the B cell side, on the humoral side. So that if we do screening, we find a lot of patients with low immunoglobulin and or IgM and or IgA. And there's a reflex to go ahead and give patients antibiotic. Well, you have to think about it's passive antibiotic collected from hundreds of people, filtered and processed. It still scares me, and it's quite expensive. And here's the deal. It has a 15-day half-life, and so you have to keep giving it. Now, CDIP, chronic demyelinating inflammatory polyneuropathy, is one indication where, I'm a little more, my threshold's lower. But I see a lot of people around the country just giving IVIG because, oh my gosh, I found a low IgG, that's your problem. That is not your problem. And I can tell you that functionally, fortunately, these patients don't equate to the congenitally acquired variable immune deficiency where they get recurrent sinus and pneumonia, thank goodness. But they are immunocompromised. And on the other side, the cellular side, we see people immunocompromised as well. So we'll work with people coming in on IVIG. We don't say it's our way or the highway. And but we do encourage people over time to discontinue it, certainly if they're getting better. And we need long-range studies to see if we can reconstitute those plasma cells who are mediated by B cells to make more IgG, make more IgM, make more IgA. Those are long-term studies. And in my short-term observation, following a handful of patients, the numbers don't change much at all.
Okay. Our next question, Dr. J, is, do we see other parasitic infections in our patients other than Babesia? We all know the answer to this.
We don't know. I mean, obviously, tremendous dysbiosis in a community in the gut that has several hundred trillion organisms. There's a lot of mischief that goes on. We have leaky gut. We have the wrong profiles. We have organisms which have dominated and don't belong there. We've lost a lot of our elemental friendly bacteria, trying to replace them with probiotics. But no question. So I think if you sent a bucket of poop to the best parasitology lab in the country, maybe Tulane, and said, all right, we think our patient has parasitosis. We can't find anything, but they respond to, several of the antiparasitics, whether it be beltricide or albendazole or Alinea or ivermectin. And they respond and they seem to improve, and we think they have parasites. They won't find anything. Now, occasionally you'll get a blastocystis hominis, which is a one-cell thing, and occasionally you'll get something else, microspora, that somebody recognizes that has mild virulence. But you won't find anything. And what I think happens is that there's all kinds of mutations and mutants being formed and hybridization going on with the spirochete and all kinds of mischief, and creating mutated parasites, which are still a problem in the gut. But so we feel like we don't necessarily do it early on, although we are using antiparasitics in our base treatments. But we will definitely pulse antiparasitics in the off weeks as our patients progress, and see what kind of response we get. And a lot of times we get a big response, and then we may rotate the antiparasitics because we want to clean up the gut to the extent possible.
Mm-hmm. This actually leads us to a really good question that one of our followers posed. Is there an order to how we eradicate these pathogens from the body? And do we usually consider mold or gut health or even metal toxicity in the blood?
So mold, if you have a severe mold problem, we have to take a time out. You need to move if possible, and that's not always possible. With all due respect to Richie Schumacher, mold does not drive this disease. It, however, is an accelerant and a deterrent, whichever way you want to look at it. And in a mold situation, it makes it difficult for the immune system to recover because the immune system in its dysfunctional state has a lot of trouble creating a lot of inflammatory cytokines that are undesirable. I'm not against treating mold, but I don't do it vigorously. Slow and gentle is best. We don't use the major chelating agents. But the main thing is to remove yourself from the environment. Now, if you go to Great Plains and you come back with some ochratoxin or one of the other toxins and you test positive, we'll say fine. But the deal is, whether it's metal or mold, we understand that can be a problem and a cofactor, but we can't treat that and the Lyme virolosis at the same time. So, because there's too much entropy, there's too much inflammation, too much immunologic confusion. But we'll get to it. And again, we're gentle. And so we use things like citrus pectin, chlorella, occasional activated charcoal, and that's about it. We don't have, in my view, good clinical tests for heavy metals stimulated by EDTA, and we don't have really good standards for measuring mold exposure, although I'm not discounting or trivializing the mold issue whatsoever, but it's not the primary agent. It can be a confounding agent, and again, if there's a heavy issue with mold, we probably can't start therapy. We probably can't get you better.
Mm-hmm. And in that case, we really do have to think about testing the home environment. and if so, remediating the home environment. There's different natural agents that can be done if cost is an issue. But certainly, just as Dr. J said, we really do have to be mindful of what our home environment is, what we're exposed to, and certainly be considerate of where we are in the disease process and what our patients' needs are. That kind of leads us to what's sort of our chain for eradicating, or if not eradicating, really putting this LBC in remission. We usually start out with pulsing antibiotics trial and transitioning to Babesia focus, and so on and so forth.
Right. So we have if you look at our website, we have a 5-stage process. And it starts with stabilization and then followed by sections of treatment, in which there are 3 sections, and then recovery, and then healing. So it's about a year process. It takes probably, if you're an IV patient who's been absolutely scorched by this illness and your life has been totally destroyed, you're probably going to need 3 years of maintenance. Otherwise 2. And I always check with the patient saying, do you want to go on? Do you want to stretch out the intervals? Because they're 1 week on and 3 weeks off. So maintenance is Monday, Wednesday, Friday with 3 drugs, Thursday, Friday with either diflucan, nystatin, and with Flagyl or Tendamax, overlaid with lactoferrin and xylitol for 3 days. By the way, just, if you're not on therapy and you're just doing the best you can in terms of trying to adjust your lifestyle, stay away from sugar substitutes, especially stevia, because they'll loosen up the biofilm big time, and that includes xylitol as well, which is what we use. And simple sugars are, to a limited extent, depending on how you respond, are okay. I prefer honey, which has less fructose than the alternatives.
And we have a really poignant question about what might be the infection driving the relentless heat or burning sensation in the body that really kind of impacts the sympathetic nervous system.
So, as you said, this is a sympathetic response. Autonomic nervous system innervates and tracks with every nerve in our body, essentially, and is definitely affected, and it's responsible for heat or cold intolerance, POTS or NMH, and also with gut paralysis, gastroparesis, slow gut, inappropriate flushing, sweating, and as this gentleman or a lady who asked the question, it can cause intense burning and heat, and along with that, you're getting some burning. Now, sometimes in regional pain, which is mediated by the C fibers, the C fibers run together with the autonomic in the same sheath with the autonomic fiber. And so both of them are getting inflamed. Then you've got a nasty situation where you've got intractable pain, don't touch me pain, tactile dysesthesia. And a lot of times you'll see rubor or redness at the same site, which is mediated by the autonomic nervous system. So, clinically learning to recognize that, we do the best we can, and that's a topic for another discussion. But the autonomic nervous system is definitely impacted. There, motion sickness and unexplained nausea, barometric changes, full moon, and so forth. So it's definitely majorly impacted and difficult to treat. We can talk about that another time.
Dr. J, you had mentioned stevia and xylitol, and we actually have a question generated from one of our followers just specifically for us to outline what are the artificial sugars patients should really stay away from and what are safe sugars. You mentioned honey, of course, but what might they consider, because we're finding that there's other things such as natural agents that may also break down biofilm.
Right, so I don't tell my patients that certain foods break down biofilm, but so for example, pomegranate, maple syrup. I just don't want to scare everybody. The main thing is sugar alcohols. And in that group, we have erythritol and stevia. Now, stevia is a natural sugar alcohol from the stevia plant. Xylitol, it comes from corn cobs and the bark of white birch. How in the hell they figure that out, I do not know. But
very creative minds.
but I've always used xylitol because I think it's very predictable and very standard in its delivery and more reliable. And it's not that I'm against stevia, it's just that you shouldn't do both. Now, if you, for example, let's say we have you on a 10-day program and you're off 18 days. And if the whole month you're putting stevia in your tea, you're creating microbial chaos because you're breaking down biofilm, and your immune system likely doesn't have what it takes to control the release of all those organisms which become planktonic, which means they're free living. And that what they do is they go invade other cells and they make more biofilm. So it's not good. So we have a very strict policy about not using the sugar alcohols. Now, I found that sucralose is also a bad actor, even though it's not a sugar alcohol. Aspartame and some of the other things that I can't recall right now, I'm a little more tolerant, but I just tell patients, just don't use them. It's just stay away and do the best you can, and to stay away from anything that says sugar-free. And again, we go back to honey and maybe organic sugars, raw sugar, maybe occasionally.
Yeah, absolutely. Especially thinking about, okay, we ask our patients to really live a clean lifestyle, reduce gluten, reduce sugar, reduce other actors that maybe pose intolerance in the gut, sensitivities in the gut. But certainly there's going to be times where we want to cheat. Perhaps the times when we do treat, it's maybe when we are on treatment so that we do have antimicrobial agents to kind of kill any bacteria released. Would you agree, Dr. J?
Yeah, so our whole concept is synchrony. We synchronize our therapy so that we're treating and melting biofilm. We stop melting biofilm. I think the xylitol, fairly short acting, lactoferrin, and then we have released, and then we go kill. And in the killing phase, a lot of times we actually treat daily because there's, we're going after everything that's been released. So in this case, at least in the short term, 5 days in a row of therapy, is something that we'll do. And then the patient's off usually for a couple of weeks. And during those 2 weeks, as I mentioned earlier, we might give them a dose of ivermectin or albendazole, or, we'd let them clear first. By the way, when patients come in to see us, we really prefer that they come in on an off week. So once they get into a rhythm and they're going through, 10 cycles or so, to get through this treatment. But once they get into a rhythm, we're looking for patterns, and I really prefer to see patients when they're on their off weeks because I want to know how their experience was on the last round of treatment, and I want to know how long it took them to wash out, to get back to feeling human a little bit. And then I want to know how long they can sustain that. And as time goes on, the period of sustainment becomes longer, and that reflects immunologic reconstitution and immunologic control. So we're shifting the paradigm. So where the immune system was confused and the pathogens dominated and persisted, pretty much we're retraining the immune system, and we're reducing pathogen load, and we're gradually getting the immune system not only strengthened but to focus and putting them in charge. So we want to hand it over to the immune system, quite honestly. We are not an antibiotic factory. In fact, half the things we use are supplements, herbals, and so forth. We use the best of the East and West.
Mm-hmm. Now, Dr. J, for some of our patients who have really major digestive issues and have a leaky gut, so they're more reactive to certain foods, what are some things that we like to suggest for our patients for kind of gut healing and support?
So I would say the major player is histamine. And we found that, so I remember years ago I was taking care of an orthopedic surgeon, got him better, but he couldn't take a probiotic like, I don't know, one of the common ones. He just said it makes me cramp, I have blue stools, I have mucus, I can't take it. I thought that was very strange. in recent years, all of us have learned that histamine plays a major role, and that certain, in the class of antibiotics and other treatment classes, they can release decarboxylase, which cleaves histidine and makes more histamine. And guess what? Some of the probiotics can do that too, some of the bacterial probiotics, and we know which ones they are. That's why certain companies have created a histamine-free probiotic package, usually only about 8 organisms. But yeah, you have to look out. It's a very sneaky thing. So the first thing with the gut is to look at are you histamine sensitive? And before that, you say, okay, here's a list of histamine-containing foods. Just need to know, acquire the knowledge that the top 12 are probably the worst. I'm not saying you can't eat them. There's strawberries and things like that, some greens. I'm not saying you can't eat them. Just don't do it 3 times a day. Because I try not to be an ogre in terms of people have to live their life, and I don't want to be too strict. But so it's just knowledge about the foods, and then it's taking things like if you have a histamine issue, diamine oxidase, which is a natural product which breaks down histamine in the gut, and which is depleted with leaky gut. So supplements of DAO are a good idea, and then other antihistamines will play in, and we won't get into that today. The rest of the gut approach, of course, is to find a combination of probiotics that patients can tolerate, figuring out whether they can eat fermented food or not. Because if you can, that's great. If you can't, that just makes it a little more difficult. Mm-hmm. Coconut oil is composed 2/3 of medium-chain triglycerides, including lauric acid, caprylic acid, capric acid. The last 2 have anti-yeast activities, but all of them have healing properties, promote adhesion, which helps the cells heal. I like glutamine because it provides the power source for healing and cellular reconstitution. We like propionic acid and butyric acid, which are small-chain fatty acids, which help the lamina propria in the gut heal as well. So for right now, that's pretty much our approach. Some patients are a whole lot more difficult than others, but you have to understand they're infected. The cells are infected, so it's just a whole different environment.
Absolutely. Now we do have a question about whether or not sleep apnea is correlated with Lyme disease, and what's our feeling on that?
So typically, as everyone knows, the lower part of the brainstem tend to get hammered with these infections, which means that sometimes you can't speak, you can't swallow, you have facial pain, you have facial droop, you have various auditory issues and visual issues, olfactory issues. But the lower part of the brain and the vagus and the ninth nerve control the hypopharyngeal apparatus, and they give us a good tone so that when we swallow, we get an appropriate reaction, we get appropriate motility to project to the esophagus. If those areas are damaged, for example, we examine someone and poke them with a stick in their throat and they don't have a gag reflex, that's not good. If we poke them in a stick and they go bananas because they're gagging and they're spasm, that's not good either. That's more of a upper motor neuron thing. In either event, you think about it. If you're sleeping and you can't swallow your own saliva because you have no muscle tone, you're going to start choking, and if you have other complicating features, mechanical features like a slightly oversized base of the tongue, you're going to have problems with that as well. On the other end, if it's spastic, you're going to be choking as well. So in that sense, yes, a lot of our patients convert to OSA, or obstructive sleep apnea, who don't fit the normal profile, and that's I think the swallowing apparatus, the throat, the paralysis or hyperactivity promote to that. So yes, you can acquire sleep apnea, and I think it's important. Our sleep emphasis is great. and very, very important, essential, I would say, to getting our patients better. And if I could just digress for a second, there are studies that show that deep sleep, which occurs in the early part of the evening, delta sleep, when the brain is really quiet, is the time when the brain venules, arterioles open and communicate with the spinal fluid and rinse the brain. So the brain gets rinsed at night during deep sleep. If you don't get deep sleep, you carry the toxins over into the next day. Not good. And of course, if you have sleep apnea or restless leg syndrome, that totally screws up delta sleep. Or if you have to go to the bathroom, your delta sleep is fractured or fragmented or, non-existent. And so, we look at it with several moving parts, and we do what's appropriate to get people into sleep.
Absolutely. Now, if we were to take that in the direction, Dr. J, for our PD population, we want to think about how sleep is vital, and that our children and teenagers need much more sleep than they typically get a night based on activity and schoolwork and sports. But we also want to think about it, just as Dr. J mentioned, that it's a time for the brain to shut down and detox. It's also a time where the brain also does its healing, and the body does its growing too. So be thoughtful about that and recognize if your child's having any sleep issues, you want to bring that attention to primary care, especially, or to also let us know if we're caring for your child too.
Well, to follow up on that, we do. So let's say you don't have sleep apnea, you're not choking, or, so that has to be fixed. Restless leg has to be fixed. Mm-hmm. But if the brain's inflamed and the sleep center in the hypothalamus is not cooperating, we frequently medicate to promote deep sleep, and there's only a handful of organisms that do that, and they're not named Ambien or Lunesta or Klonopin. Now, there are two phases that we're pretty simple folks here. We're just trying to get along with other doctors and medical boards and so forth. And so we're simple, and we talk about sleep as initiating sleep, which really doesn't promote the entire evening's quality of sleep. But getting into sleep, you have to start with that. And we try to stay away from benzos, but if we have to use them, we have to use them. So, we use options, which I won't get into, which are not habituating. But in any event, some people don't have trouble getting to sleep. It's just they can't stay asleep, or they don't, So other people can't get into sleep, and once they're asleep, they do pretty well. So, and most people have both. So you get into sleep, and then there are a handful of medications. And I'll mention just a couple. One is gabapentin, one is pregabalin, which is Lyrica, one is oxcarbazepine, which is Trileptal, one is trazodone, Seroquel, mirtazapine. So we typically choose from that group to promote deep sleep. And there may be others that are being developed that will do that, but there are a lot of medications used for sleep which do nothing of the sort and are to be avoided.
Absolutely. And to tie that in, what Dr. J just mentioned, some of those medications, we do feel comfortable utilizing PD population, but we're very thoughtful about that and are very thoughtful about the dosage in which we start them at, including the adults too. We have very safe dosages that we start and titrate and monitor very closely. So another question we have actually is about what's our thoughts on utilizing hyperbaric treatment and where it has a purpose.
That's a good question. So hyperbaric's wonderful. This country is retarded in terms of how it's used. The UK, France, Canada, Japan. There are literally dozens of indications for ancillary use with HBOT. When you have an inflamed brain, it's contraindicated. So I know that there are reports of people going through HBOT and taking antibiotics at the same time. Not a good idea. You may survive it, you may not. The reason is that, especially if the pressures that they use. Now, so most people know about atmospheric pressure, so 1.0 is sea level. if you go up to 1.8 or so, that's like 12, 18 feet underwater. If you go up 2.4, that's 40 feet underwater. And you seldom go up to 3.0, which is the max. And these are in the hard chambers, by the way, because you may know that there are soft chambers out there that you can buy and put in your home. I think HBO is wonderful, but I look at it as a healing process. So once you come to our clinic and we feel after a few months that we've purged these infections and now you're ready to heal. Remember, infected tissues cannot heal, and you won't have the opportunity to heal unless they're eradicated. And we feel confident that we've eradicated 95% of the pathogens and put you in a position where you can heal and regenerate. And I think HBOT plays a role. However, it should be at lower pressures. So people ask for HBOT. I've done HBOT. I had HBOT in my clinic in Charlotte, as a matter of fact. I had, outstanding units. I had a former Navy SEAL diver who was running it. And we never got traction there, as my history indicates. So I've known about HBOT for a very long time. If you use lower pressures, I think that's the safest way to go. And I would mean that no higher than 1.8, preferably 1.6, 1.5. The soft chambers at home can go up to 1.3. And I used to think they were worthless. I don't think so anymore. I think they're probably helpful, again, with the proviso that you're healed. Or, we consider you healed. Then I'll say, okay, go ahead and use it as an adjunct if you have the money to buy something at home. I do think 1.3 is fine. You can reinforce those things and get up to 1.5. So 1.3 is like 8 feet of water, 8 feet underwater. What happens with HBOT and the oxygen that you get, 100%, there's no other way to increase your free oxygen. The oxygen bars are garbage. Hyperventilation won't help. You have to do it under pressure. And what happens, that the tiny percent of free oxygen, unbound oxygen, is what gets into the cells and provides, it gets in the Krebs cycle and makes things go. How do you think fish survive? I mean, you think there's, tons of oxygen in the water? No, there's just a little bit of free oxygen. That's all they need. So with HBOT, you can get a 20-fold increase in free oxygen, if not 50. And it has marvelous properties in terms of apoptosis and cellular reconstitution and increased vascular influx and even improvement in some of the distribution of the medications that you may use. Although I don't advocate treating with antibiotics at that time. You should be better before you get into it.
Absolutely. Now, going in this direction, kind of changing things for a little bit, kind of talking about COVID-19, there's certain medications that we prescribe that patients have questions about, that certainly, like hydrocortisone, that might have a little bit of immunosuppression, but it's certainly vital to combat adrenal fatigue. What's your thoughts on them continuing to dose it? Is there any concerns about rifabutin and increasing likelihood for acquiring COVID?
I'm not aware of any problem with rifabutin in acquiring COVID. I've just given you a COVID protection package. As far as hydrocortisone, look, we give it as replacement physiologic so that you don't die from adrenal crisis. Again, the pituitary is hammered, and the ACTH is made in the anterior pituitary. Stimulates adrenals to make cortisol. Sometimes there's synthetic problems with cortisol production, so sometimes it'll be a combination, but usually it's what's called secondary hypocortisolism, which means the pituitary is not sending enough ACTH. So we'll do a paired ACTH and cortisol in the morning on our first fasting, on our first review. If that's suspicious, we may do a salivary cortisol. And if that's confirmatory, you're going to be on hydrocortisone. Our bodies make 35 to 40 milligrams of hydrocortisone a day. Our replacement is on the order of, maybe 10 to 15 or up to 20 milligrams a day, taken in the morning, separately in the morning, divided doses in the morning, noon, and hopefully in the mid-afternoon if you can remember. These are replacement doses. These are not immunosuppressive doses. to be immunosuppressed, you'd need 50 times that much. You'd be taking prednisone, which is 40 to 60 times as much, and that is immunosuppressive. It interferes with nuclear kappa, gamma, and is the most potent inhibitor of immunologic function on the planet, and used to be used like candy by everyone. And I hear they want to use it for COVID, which I think I'm fine if somebody's in the ICU, an inflammatory storm, about to die. That's fine, but not as a prophylaxis, please.
And we actually had a question from one of our followers online. If in the future a COVID-19 vaccine certainly is discovered and has some traction with it, is it something that we would likely consider for our Lyme patients? And certainly it's maybe too early to tell too.
I think it's too early, and I would not, especially our label patients. We know that immunizations of various kinds are disturbing to the immune set and can provoke symptoms and send people on a very bad course. And especially in the light of the fact that this has been rushed, if we get something this fall, it's still going to take a long time to figure out whether it's effective and whether it's durable, and if it does develop antibodies, what percentage they last, and how functional they are. So no, I would say no. We would use our protection package and supplement package, do everything we can to do an orderly treatment of the Lyme borreliosis, so the patient has restoration of their own immune set. In the future, we may do some HLA testing to see, because we know which of the alleles is a problem, and so we may do some HLA testing of our patients to see which of the low-risk group is immunologically vulnerable, because everybody's scared to death about after you hear somebody 35 years old and healthy dies. Well, it's because they have immunologic vulnerability, and that's something they were born with.
Mm-hmm. Now, just to kind of change gears, we've got some cosmetic type questions for some of our adults who maybe are interested in pursuing something like breast implants or lip injections, maybe even something with botulinum toxin. At what stage will we recommend that for our patients? Is it something that we would support, and how could they do that safely?
So the botulinum is interesting. We have a lot of people come to us on that for headache control and do well with it. It's every 3 months, and we're fine with that. There is a condition called cervical instability, in which the ligaments and tendons of the supporting neck structures are inflamed and become hyperextensive. And my concept is that it loops the we get neural loops, which lead to, exciting some of the cervical nerves, which then excite the trigeminal nerve, and they get these horrible headaches and further weakness. So if they have weakness associated, some people can't hold their head up, because of the damage done. And I've had a handful of patients where they get Botox, and they are just miserable for 3 weeks until the stuff wears off. But for other people, headache control, I'm all for that. And for dystonia, I'm all for that. I don't have a problem with that. I think Botox is fine. As far as some of the other questions, the lip injections, I think would be fine. I mean, correct. Maybe a little later in therapy, that's kind of nice. Breast implants, not from what we know. I mean, you have to understand that there is a risk of being infected with these stealth pathogens, and we've seen that. And I would definitely hold off on that.
Mm-hmm. Now, for some of our patients too, something else that's cosmetic is laser therapy to treat skin. Okay. I apologize, we might not have time to answer that question, but we really are thankful that you were able to join us today for our 4th installment. Please look forward to our 5th installment next month as we eagerly await your questions. Some, I apologize, we weren't able to get to today, but we'll compile a list and make certain that we address them next time. Thanks again for joining.
Yeah, so again, it's a privilege to do this, and just awestruck by the number of followers that we have, and I hope we're providing good information, insight, and I feel very good about that. But again, it's a privilege and honor to work with you all.